In this lecture, what we're going to do is to look at when should reassessments of outcome measures take place within your clinic. And we'll talk a bit about growth curves, which is a type of graph that you can use to follow the progression of a patient's improvement over time or for his or her condition, and also look at why is it important to look at a optimal time for reassessing patients. What is the purpose of that? So firstly, what is the purpose of reassessments? Well, as you are a clinician, you will know the reason why we reassess in our clinics is to essentially find out how patients are doing after they have received our treatment. So how do we reassess them clinically? We simply redo some of the objective or subjective tests that we have administered in our baseline assessment. That is the very first time we have seen the patient. As we do that, as the scores improve on these objective or subjective assessments, we will know that the patient would have improved. So the next question to ask is, because we are reassessing probably at every single time that the patient visits us, is there an optimal time to reassess patients? Well, according to the textbook that we have been following, Riddle and Stratford, according to the authors, there is actually an optimal time to reassess patients. In practice, however, we will know that for short periods of time, if the patients we know are only going to be with us for several weeks, it is much simpler to reassess them every single time. However, for longer term patients where they will be with us and will be on our portfolio for quite some time, there is probably a need to optimally assess them. Or perhaps if the patient has a long-term condition and then they are only there to see you every several weeks, therefore there is an optimal time to reassess them, and you can coincide these with the correct time to come and visit you. When we do reassessments, there are many ways of doing reassessments and how we would decide when to reassess patients. In this particular module, what we are going to do is approach it from an information-driven approach, whereas in terms of we are going to use research literature as well as evidence that's been published out there to help us determine when's the best time to reassess and why do we reassess during these times. The method that we'll be going through will be called growth curves. Now, growth curves have been used in biological as well as physiological topic areas and disciplines when they actually plot perhaps bacterial growth or the decline of a specific population within the wild. However, growth curves can also be used to describe epidemiologically how a person's condition actually progresses. So we're going to use that approach to actually look at reassessments in this seminar. But one thing to remember is that within allied health professions, growth curve isn't a commonly used method to look at the progression of patient's condition. Therefore, what we'll do is discuss some point within this short lecture the approach using different types of longitudinal studies that actually looked at different times and then add them up together, put them together, and then plot a growth curve ourselves in order to get a basic idea of how on an average person actually progresses for a specific condition or patient characteristics you are interested in. Growth curve, when used for reassessment purposes, there are two basic assumptions or requirements that we need to bear in mind when we look at some literature that helps us to plot the growth curve. The very first assumption is that the patient population that is investigated in the research itself has to be representative of what you're trying to look at in your own clinic. Obviously, if a research study was, let's say, looking at the progression of pain as the condition progresses for a rheumatoid arthritis population, that would not be relevant to you if you were mainly seeing chronic low back pain patients and trying to determine how their pain actually progresses as time goes on, because these are completely different patient populations despite the fact that the outcome measure is the same. So that's the very first assumption. Occasionally, you might come to the point where there might not be actually a study that has got a patient population that is representative of yours. If that's the case, then what you need to do is to look at the closest thing that you can find, and hopefully that will be able to help you address the requirement of you tracking the progression of your patient of interest. The second assumption and requirement is that the study data within the literature that you collect, the data itself has to be missing at random. What is meant by missing at random? Missing at random is essentially data that is missing within a study that the authors have reported, but is not as a direct result of the outcome measure or the condition that they are trying to measure. Let's say, for example, if we were to measure a person's, within a study, there is data missing from a rheumatoid arthritis population about their pain intensity outcome. There are some missing data, and through further sort of investigation, the authors find that the rheumatoid arthritis people did not come to the clinic or the research study because they have actually an increase in pain due to a worsening of their condition. Now, if that sort of missing data is not missing at random, what is meant by missing at random is, let's say, for example, one of the patients missed a bus and therefore wasn't able to get to the clinic in time for the data collection, for the research. Or perhaps the weather was so bad that the patient could not travel to the clinic for the data to be collected by the researchers. Now, these data are then classified as missing at random. So when you read a research paper and when there is missing data, you have to then ask, by looking at the method section as well as the results section, whether the study data is missing at random. How do we then use growth curves if we have collected some literature on them for looking at our reassessment times? Well, the first method is when we have a study that already has a growth curve being plotted out for improvement. As I said before, for allied health profession research, this is fairly rare. But if there is a particular study that actually already has plotted out a growth curve for you, then you can simply use that particular study to help you determine when is the optimal time for you to reassess your patients, and how you then set your target goals, as well as the duration of when you should actually measure the improvements. Method 2 is when you don't have one study that has a growth curve being plotted out for you. If that's the case, then what we'll need to do is have a strategy for systematically searching for studies for the patient population of interest as well as the outcome measure of interest, so that you can collect these studies, which we hope are longitudinal. That is, they have got multiple reassessment times. Let's say, for example, baseline in week 0 to week 4 to week 8. Then what we can do is accumulate them and then get a rough idea by averaging out all these studies for their different reassessment times for us to plot out our own growth curve. Within Stratford and Riddle's book itself, they have outlined a simple method of doing that. Of course, using this method of accumulating literature, you have to then have the necessary skills to collect these data, do a systematic sort of search, collect these data and studies, and then plot them out as you are looking at the slide right now, in terms of listing out the studies and then looking at the values for the outcome measure of interest. In this case is the sort of post-arthroscopy knee flexion range of motion. And you can see that each particular study indicated as source they actually reassess their patients at different time points. For example, Kumar has reassessed the patients at week 1, week 6, and week 12. However, if you look at Peterson, they've only assessed the patients at week 12 and week 52. It is probably a good thing that different studies have different reassessment periods, because what we can do is that put them up into this particular sort of grid pattern and then calculate the average for the different types of weeks. With multiple time points, let's say in this case, we have got weeks 1 to 52, we can then use these average range of motion for each time point to plot out a much more smoother curve. In this slide, you can see that the scan image of the growth curve is an average of all the different studies. So this is what you can do to plot out your own growth curve. It may mean a little bit more work as compared to just using one study to look at the growth curve, but it is actually worth the effort because it will give you accumulation of evidence. Now the next question we need to ask is, when is an optimal time for reassessment? Is there an optimal time for reassessment? Well, Riddle and Stratford argues that there is indeed an optimal time for reassessment based on the accuracy of how we would classify someone as having improved. So they argue that if we reassess a patient too early on, the chances of misdiagnosing the person as having no improvement increases. Okay. On the other hand, if we reassess them too late, this increases the chances of misdiagnosing someone as having improved. Well, how do we know that? The answer to knowing whether reassessing too early or too late actually increases the chances of misdiagnosing is actually shown in this particular table over here. As you can see in the middle column, when we actually optimally assess the patient, that is at just the right moment in time, the amount of false positive as well as the amount of false negative diagnostic inaccuracies actually is constrained so that the total amount of misclassification is standing at 39%. Now, on its own, that figure does not mean anything. However, if we reassess the patient too early or too late, what we'll realize is that if we assess the patients too early, the false positive actually increases in terms of its percentage compared to when we reassess the patient at just the right moment. You can see that the percentage for false positive is 57% as compared to 25%. Okay. However, the false negative actually reduces if we assess the patient too early. But we're not very interested in just these two false positive and false negative on their own. What we are interested in is the total percentage of misclassification. And if we add them up together in terms of the false positive and false negative, we realize that we get a misclassification percentage of 61%, which is about twice as much misclassification as if we optimally reassess the patient at the right time. Now, if we reassess the patients too late, what we realize is that the amount of false negative actually increases as compared to if we optimally reassess the patient. So in this case, looking at this graph, the false negative is actually at 40% as compared to when we optimally reassess the patient is at 14%. Interestingly, the false positive is decreased compared to when we optimally reassess them is at 8%. Again, we are not just interested in the individual false positive or false negative, but we need to add them up together. If we add up these two errors together, we get a misclassification percentage of 48%, which is again much higher. So, in summary, we talked about the idea of optimal reassessment and that there is a time for optimally reassessing the patient. And how do we use that? One method is through the use of growth curve. In order to use growth curve, we need to know some of the assumptions associated with growth curve, as well as if there are no research that has got one growth curve, what we'll need to do is collect a series or multiple research in order to plot a growth curve of our own in order to decide when to optimally reassess our patients. So I hope this mini lecture will be able to convey some of the key ideas of the use of growth curve for optimally reassessing patients.